be helping facilitate today's webinar. And as you just heard, today's webinar is going to be recorded and it will be available on our website as well as the slides in about a week. And we'll also send that out to you by email. As I mentioned from the start, today's webinar is hosted by Max for Moms, which supports prescribers in their practices in addressing the needs of their pregnant and postpartum patients with any substance use disorder questions or chronic pain management. And all services are free, including phone consultation for clinical questions, help with finding substance use resources and information, as well as education and training opportunities, just like today's webinar. So please feel free to reach out to us for support. We are happy to help. As Marciel put in the chat, our information is there as well. Before we dive in, I'm going to quickly go over some housekeeping items in the process for earning credit for today's training. In order to get CE credit, you do need to be on for the full duration of today's training, and you must complete the evaluation survey within 7 days from today. That will be available immediately after today's session by logging into your OASIS portal. And you'll also be able to access your CME and CEU certificate in that portal after you complete the survey. Throughout today's webinar, you can certainly use the chat for any questions that you might have, and we'll have time at the end of today's session for any questions. I'm now happy to introduce our speaker for today. Today we have with us Dr. Courtney Townsell. She is a tenure-track assistant professor and the director of perinatal research in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of Maryland. Dr. Townsell is dedicated to the full spectrum of maternal fetal medicine with a particular focus on perinatal substance use and abuse. She serves as the MFM lead for the support practice at the university and is a consultant for Max for Moms. As a clinician scientist, Dr. Townsell has expertise in clinical and translational research. Her current research program centers on placenta transport and metabolism of opioids and strategies for preterm birth and prevention. Her work is supported by foundation funding and NIH grants. In 2024, she was honored with the Robert Wood Johnson Foundation, Harold Amos Award, a prestigious four-year career development award. Additionally, Dr. Townsell is an innovator holding two U.S. patents for a new medical device aimed at reducing preterm birth. She actively contributes to the academic community as a member of several national boards and committees, including the editorial board of the journal, the ACOG Fetal Alcohol Spectrum Work Group, and the DEI Committee for the Society of Reproductive Investigation. Thank you so much, Dr. Townsell. I know that probably didn't even cover half of what you all do, but thank you today again for being with us today, and I can turn it over to you.
Wonderful. Thank you so much for having me, and I'm excited to give this talk today. I'm going to quickly just introduce Cheyenne Somerville. She is my partner in our clinic, our support clinic. So Cheyenne is here. She's a peer recovery counselor in our clinic, and she and I will do some Q&A after this didactic portion of the presentation. So today we'll talk about understanding the whole patient, social drivers of health and perinatal substance use. I do have one disclosure. I am a paid consultant and equity holder in Origin Solutions for intellectual property that's unrelated to this work. We won't discuss that today. Learning objectives for today. So after our discussion, we'll be able to recognize social drivers that influence substance use during pregnancy. Hopefully, you'll be able to understand the impact of stigma and structural barriers on care engagement for our pregnant individuals with substance use. We'll explore some patient-centered approaches to support pregnant individuals navigating substance use and social challenges. And then lastly, we'll identify opportunities for interdisciplinary collaboration to improve maternal and infant outcomes. So we'll get started. So to set the stage, I just want to sort of just go over some of the things you may know. We are continuing to be in this epidemic of substance use in the United States. Over 40 million individuals, that's 16% of our population, had a substance use disorder in 2020. 94% of those did not receive any treatment at that time. COVID-19, as we know, worsened the overdose epidemic and the crisis that we experienced. Individuals were really isolated during that period of time. Depression was really high, and we saw increasing rates of substance use during that period. In 2021, opioid deaths topped 80,000, which was a tenfold increase since 1999. And similarly, we saw increasing rates of stimulant use and stimulant fatalities as well, with 32,000 deaths related to stimulant use. When we transition and think about pregnancy and substance use, we also see really high rates. Past month substance use among pregnant individuals is sort of in this image. And what we see is any illicit drug use was about 5.8%. So, you know, 1 in 20 patients that come to the clinic in a day might have substance use. Tobacco use was even higher at almost 10%. And then again, alcohol use, very common substance in pregnancy as well as marijuana. So in a typical day when we're seeing patients and we're interfacing with our clients, it's not impossible to have 1 to 2 patients who may report some substance use. And again, this is just a look at substance use in pregnancy and where patients are. So we look at all locations, rural and urban areas as well. So again, you can see in the blue bars that the rural areas tend to have patients with higher rates of substance use diagnoses. We see that across opioids and stimulants, but we're also seeing substance use in our urban areas as well. Cheyenne and I can attest to that, working in inner city Baltimore. So I just want to take a moment to talk about the impact of this substance use in pregnancy. Again, we see high rates of maternal morbidity as well as mortality. When you look across, any substance use, opioids, cocaine use, stimulant use, what we see is high rates of preterm birth. And again, our average gestational age in our perinatal substance use clinic is about 36 to 37 weeks. We certainly have moms that go beyond that. But we certainly have moms who fall short of that as well, and it's oftentimes related to their substance use or complications of substance use. And so just things to be aware of. And in this state, substance use disorders are a leading cause of maternal mortality. So in Maryland, substance use disorders accounted for about 28% of pregnancy-associated deaths between 2011 and 2020. So that's 114 moms that are no longer with us as it relates to substance use disorders. And only in 2022, which is the most recent data that we have, did substance use disorders and overdose deaths fall to number 2 in terms of leading causes for maternal morbidity and mortality, with postpartum hemorrhage now leading the way. But it remains a significant issue for those taking care of these patients, and something that these patients are facing. And I think the big question is really, why do patients use substances? Why do they use drugs? We think about things like medical treatment, maybe for pain, health conditions, maybe simply recreational enjoyment. But a big reason why many patients sort of find themselves using substances is really stress and coping from some of the things that they're dealing with. There's also some peer influence, performance enhancement, and curiosity, but by and large, stress and coping seem to be at the top of the list. And just to give a little bit more background with relates to the pandemic and the COVID-19 data that I presented, during the first year of the COVID-19 pandemic, the global prevalence of anxiety and depression was about 25%. So 1 in 4 individuals were feeling anxious or depressed. And these were major factors, social isolation, people's inability to go to work. They weren't able to see their loved ones. They had really minimal engagement with communities. And what we saw was that pandemic-related substance use, particularly in pregnancy, increased. And so you can kind of see pre-pandemic is sort of the darker bar, and then during the pandemic is the lighter bar. And for fentanyl exposure and tobacco exposure, particularly, we saw significant increases in those substance exposures and pregnancy during the pandemic. And so that leads us to social drivers of health. And, what are social drivers? And I think in the past, we've heard things like social determinants of health, but we've moved away from this term of determinants because we don't want it to be finite. It doesn't determine, your end, and it's not something that's not movable. It's a driver and it's something that we can navigate and hopefully affect change. And so, just want to go through a couple of these social drivers of health. So the first is economic stability. And so whether patients are employed or not employed, the medical debt or the support that they have, neighborhood and physical environment, whether the patients are housed or unhoused. We see a lot of housing insecurity in our patient population. One of the top issues that patients are dealing with. Education, patients' health literacy, literacy in general, their access to higher education. Food is another one, and a lot of patients having issues with access to food and food insecurity. Another driver is community and social context. And so this is, again, the social support that people feel, whether they feel stressed, whether they're exposed to violence and trauma in their community, and then the healthcare system, whether individuals have healthcare, have enough healthcare coverage, and the quality of care that individuals have. And across all of this, we see something racism and discrimination and how many of these social drivers impact or intersects with racism and discrimination as we think about things like redlining and the populations that those impact, um, food deserts and things like that. Those issues and barriers tend to often impact patients of color, and those are things to just be aware of. And all of these things sort of amount and sort of trickle down to what we see at the bottom, which are the health outcomes, the maternal morbidity and mortality, the healthcare expenditures and functional limitations that patients experience. And so, for social drivers of substance use in pregnancy, some of the main things that have been referenced are things like poverty, housing insecurity, again, racism, and access to care impact substance use risk. And we know that chronic stress from things like social adversity can lead to biological changes affecting pregnancy, and that patients who experience disparities in their maternal outcomes, typically our patients in marginalized populations, tend to have higher social drivers. And then we know that environmental stressors can contribute to substance use and poor outcomes. And so, a little bit about social drivers of health and opiate use disorder. I had a medical student here at the University of Maryland who was very interested in how social drivers impacted patients with substance use. And so we took on a little retrospective study. And so Jane is one of our now fourth years. And she wanted to look at the association between social drivers of health and risk of maternal morbidity in our patients with opiate use disorder during pregnancy. So we conducted this retrospective chart review of pregnant individuals with opiate use disorder who delivered at our university between 2017 and 2023. To identify these maternal morbidity, we use the CDC indicator. So there's about 22 of those. Um, and we looked at those across each of the patients that were included in the study. And then we also looked at whether or not individuals had any of these social determinants or drivers. So whether there was insurance vulnerability, whether patients were single or married, employed or unemployed, had financial stability, transportation, a support person, and history of incarceration. These are things that we got from the electronic medical record. And just to highlight a few things, our population was about half Black and half white. There was a pretty high rate of comorbid conditions such as diabetes, hypertension, a very high rate of mood disorders in this population, about 62%, which is not uncommon in patients who have substance use disorders. And only about 45% or about half of the patients were receiving treatment. Again, other things that we noted, prenatal care. So about two-thirds of patients receive prenatal care. Um, and then just looking at some of the neonatal outcomes, we see, you know, generally the gestational age was again preterm around 36 weeks. And so a couple things that I just want to highlight in terms of the social determinants or drivers of health that we saw in this population. The vast majority of patients had Medicaid insurance. The vast majority were single, so 79%. And when we looked at employment, the vast majority were unemployed, 67%. And so those are just some of the drivers that we were seeing in this population. We had sort of less reliable information about transportation and financial stability. 95% of individuals reported no support person, and then incarceration was about 2.9%. And what did we ultimately found? So we found sort of this response related to social drivers and the burden of social drivers. So as you look, the more social drivers a person was experiencing, the more likely they were to experience maternal morbidity. And so that rate increased with the higher burden of social drivers. And there's more data. This is under review, and hopefully we'll have this out and available for others. And so just to drive this idea home that social drivers aren't just things that people are experiencing, they're also impacting the outcome, the pregnancy outcome. And so a couple of other studies have also found interesting findings, right? So there was an analysis of reproductive age women, aged 15 to 49. And simply pregnancy alone was not associated with substance use or treatment seeking. So we often think of pregnancy as a time for patients to seek care or to sort of improve so that they can have a better situation for their infants. Um, but that wasn't sort of found in this one study. They did note that in past months, substance use was associated with higher education attainment and annual income that was less than 20,000. There was a history of criminality in this population and also having health insurance. And those who did seek treatment tended to be older, have an annual income that was greater than 20,000, again, still had some criminality history. And so I think what we know is that those social drivers are prevalent in our patients with substance use disorders, and that they certainly impact their outcomes. And so now we'll talk a little bit about stigma and structural barriers to care for this patient population. So I'll spend a little time with stigma. I think things that we all know, stigma operates at many levels, the individual level, interpersonal, and institutional. This population is frequently asking questions about child welfare and who will be involved. And there's a lot of stigma around criminalization of substance use in pregnancy, which is, of concern and something that we need to continue to work through. I think also the language that we use and the attitudes that we portray really affect the way a patient is able to trust or not trust and engage. And so, just thinking about how we engage our patient population, and then lastly, how intersectionality of things like being a person of color and other things amplifies that stigma. And so these are just a couple of examples of stigma. I think we're aware of sort of public stigma and public shame that sort of comes with substance use disorders and having a substance use history. The structural stigma and health practitioner stigma that might come from an institution. But it's also important to know that there's self-stigma and perceived stigma that patients are experiencing every day. I mean, I think when we have our patients come to our clinics, they have the feelings that they feel as they walk in, label avoidance, they don't want to be labeled. But they also have their own internalized feelings of stigma, and so they don't need that compounded by stigma that we are portraying or putting onto them. And so why is this important? So some of the effects of stigma, the biggest thing is reduced access to care. What I frequently see is that patients enter care later. Um, and because of that, there's poor quality of life, delayed diagnoses, and increased morbidity for patients. So a later diagnosis that we certainly could have hopefully, treated more appropriately with more notice, or a diagnosis that we could have given earlier and had a longer time to treat. And so we don't want patients to feel like they can't come and that they can't seek care. We want to embrace them and take care of them just like we do any other patient. So with that, our words and our actions matter. So it's really important for not only the clinicians, but everyone who's going to interface with this patient population to be kind. The front desk staff, the officer at the front who's sort of navigating people. Be supportive, be caring, be empathetic. It's really important. And these are just a couple of things in terms of the language that we're using. I typically try to use person first language. So, a patient with a substance use disorder, not an addict, not describing that person. We're talking about the person first. So, this is a person. And then we're talking about the diagnosis that they have diabetes, chronic hypertension, but they're not the hypertensive patient. They're the patient with hypertension. And so just thinking about a lot of these things and how we use these terms and how we refer to the patients that we're interacting with. And so next, I just want to explore a little bit about patient-centered approaches and how do we support patients and individuals navigating substance use and social challenges. A lot of the patient-centered approaches really center on having a trauma-informed and family-centered atmosphere for patients. This really increases engagement and improves outcomes. Some of the models include harm reduction, peer support, and integrated behavioral health. So this is really sort of meeting the patient, understanding what their goals are, where they are on that readiness ruler. Are they ready to transition to treatment? Are they not quite ready? What would help them get ready? What are the barriers to being prepared? And thinking about adjuncts like the role of doulas, peer navigators, and community health workers to support the care that we're providing in our institutions. And then lastly, just centering the lived experience that really can help drive equity in the care that we deliver. One of the big things that I impress upon some of our trainees is just really understanding the experience and what individuals went through, what their story is. How did they, how did this whole situation start? No one just wakes up and wants to use substances and wants to use drugs. That's just not how it ever works, right? There's something that has triggered that, right? Maybe it's the car accident and then they were put on medication and they just couldn't get off. Maybe they tried something or they were so depressed. And so really trying to understand that person's story, and not just seeing words on a chart. Harm reduction is compassionate care, and this is really important. I can't impress this enough. Certainly, treatment is critical, and we want patients to consider medication for opiate use disorder or other sort of medications that are out there. But it's important to also understand that there's a spectrum of ways that we can help patients and improve their care. Making sure that all of our patients, particularly those with opioid use disorder, have access to Narcan, naloxone rescue kits. There's syringe exchange programs, thinking about pre-exposure prophylaxis for things like HIV, making sure that we're testing everyone for Hep C, HIV, and educating about prevention and treatment. And really, harm reduction really is trying to elicit any positive change, whether that just be coming to all of your prenatal visits, making that ultrasound visit, getting all your blood work done. It's any positive thing that's going to improve the outcome for the pregnancy. A little bit more about trauma-informed care. So, just thinking about this patient population, we talked a lot about the high rates of depression and anxiety, but 80% of women seeking treatment for addiction history report physical or sexual assault history. And so, these are reasons why patients may delay coming to care. These are things that they have to still overcome. And then women with substance use disorders are more than 12 times more likely to suffer from post-traumatic stress disorder than those without substance use disorders. And so it's not just that patients don't want to come, there's a lot of barriers in the way for presenting and engaging in care. And so these are just a couple of things to keep in mind when we're caring for patients. Certainly, we want to center their substance use and understand whether they're ready for treatment, but recognize that there's some trauma, some stress that might be related to that, address any depression and anxiety, and think about the social drivers. So it's not just thinking about that top box, but it's really how do we sort of deal with all the things a patient is dealing with, the whole patient. One of the things that I like to say is, it's not uncommon for us to interface with a patient who is upset about something, is angry about how someone made them feel, how someone talked to them. And really important for us to think about how we respond as individuals, right? So we are tasked with caring for all patients who walk through the door. And instead of thinking of things like, why is this person acting like that? I try to reframe those scenarios to say, what happened to this individual to make them respond in this way? Make it less about me, less about my team, less about the people in front of them, and really center back on the patient and try to understand how do we help this person navigate the situation that they're in. And some of the things to just be mindful of are some of the trauma-informed care, the 4 Rs. So realizing that trauma is widespread and common. So pretty much anybody who comes into our offices, our clinics, our institutions, they could have experienced a history of trauma. Recognizing the signs of trauma, so when patients are tapping their legs or sort of distracted by the phone or there's many different signs. Cue into that. Sort of don't just go down your script, but really say, is there somewhere you need to be? Is there something that you're worried about? Um, what's going on so that you can really understand the experience of the patient. Respond by fully integrating trauma-informed policies. So many times we have policies that don't center the patient. In obstetrics and gynecology, it's not uncommon to have policies where children are not allowed. And again, that's just not reasonable when we're dealing with reproductive age individuals who are typically coming in pregnant and probably have been pregnant in the past. And so just thinking about the barriers that some of these policies may introduce without any mitigation strategy. And then lastly, we want to resist re-traumatizing individuals. Again, sort of when patients come, again, there's a high rate of sexual assault and physical abuse in the past, about 80% of these individuals. And so thinking about how we talk about doing the physical exam and how we approach those exams and getting permission to do those exams is really important. Some of the core principles, again, just thinking about a trauma-informed approach. Again, trauma is prevalent. So just if we assume that everyone has had a history of trauma, then we will sort of treat everyone equally and sort of have that empathetic tone and approach. Thinking about just creating a safe space, coming with humility and responsiveness. Being trustworthy and dependable. It's so important that if we say we're going to call a patient back with information, if we say we're going to send them something, that we do it, that we be the people that can be trusted and be depended on. Collaborating with others. I think there's so many individuals in someone's care team that it's important that we all be on the same page about what it's going to take to care for the patient in front of us. Again, being compassionate and empathetic. But again, making sure that we're taking care of ourselves so that we prevent our own burnout. So checking our pulse and our temperature when we find ourselves in scenarios and just making sure that we are in a good headspace to care for others. Um, I think this is just a little bit about how trauma changes trust and functioning and help seeking. I think when individuals experience trauma, um, it changes how they see the world around them. It changes how they interact with individuals, and so that might result in some emotional dysregulation and some psychological isolation. We might see that patients sort of retreat instead of engaging. This is a time where we would expect that, if you become pregnant, that you want to come and you want to seek care. But we also have to think, how does trauma work and what sort of maladaptive properties might be present in someone who's experienced trauma. And so some of those changes in behavior that we might see are low help seeking behaviors, mental health problems, um, and poor parenting. So those are areas that we want to support. And I just wanted to share some of these images. Like when we talk about trauma and we talk about stigma, these images are not for me to educate you with. They're for me to show you, like, these are the ways that we talk about our patients. These are the images that patients have to interface with, um, where they could be monsters or they're intentionally trying to hurt their babies. And these are things that we really have to try to stay away from as we are creating educational materials and as we're making these campaigns to connect with patients. This is not the way to do it. So I just wanted to just shine a light on even with well-meaning, sometimes that we can be the ones to kind of re-traumatize and provide that stigma. So lastly, we'll identify a couple of opportunities for interdisciplinary collaboration, which hopefully improve maternal and infant outcomes. So this really talks about the integrated care teams that we have. So when we have OBGYNs, addiction medicine, psychiatry, neonatology, social work all at the table, we can address all the concerns that patients may have. As an OBGYN, I can't always speak to, some of the things that the neonatal team or the pediatric team are gonna have questions about after the delivery. And so it's so important that we all have, open communication. Collaboration with legal systems, housing services, behavioral health, all of those improve continuity and really improve engagement. I think, I'm interested to hear from Cheyenne in just a little bit to talk about some of these services, but really to say, how do we interface with housing services or know about housing services that are available for our patients so that we can sort of direct them when those are the most significant barriers that they're facing. For us, it's like, I want you to come back every 4 weeks and I want you to come to this ultrasound. But if a patient doesn't have a place to lay their head, if they don't have food to eat, it's hard to hear all of those recommendations. Interdisciplinary clinics have shown promise, and I'm, proud to work at the University of Maryland where we have some our clinics, we have our social workers present, we have our psychiatrists across the hall, we have a lot of our resources present for patients. And then again, just looking at some of the case models and lessons learned. So this is just to highlight our support clinic. It's a substance abuse in pregnancy and parenting outpatient recovery and treatment. This is the program that Cheyenne supports us with. I've also worked in another perinatal substance use clinic, which is partnering for the Future Clinic that was out at the University of Michigan. And really, both of these clinics have different ways that they've integrated care. On the right, the image shows all of the different services that we had at the University of Michigan in our perinatal substance use clinic. Patients were connected to anesthesia, social work, obstetrics care, physical therapy. Many patients started out with some sort of chronic pain, and that's really what led them to continuing using substances. We also had addiction medicine. And here at our current center, we offer medication for opiate use disorder. We have peer recovery support, information about parenting and childbirth preparation. And so really thinking about what are all the services that a patient may need. And that model, again, from clinic to clinic and hospital to hospital may look different, but it's just important for us to center the patient and think about what other clinician or provider could be helpful in the care of the patient in front of us. One thing that I just wanted to highlight, we do have from our psychiatry colleagues a program called Mom Power. Um, this is a 13-week manualized sort of trauma-informed mental health intervention for patients with substance use disorders. We had this at the University of Michigan, and I'm excited that we have this also at the University of Maryland. They've gone through a couple of cycles of moms, and it's just, again, another opportunity for us to not only provide sort of health care, but to provide sort of life care, where we're thinking about the connections, thinking about self-care, teaching patients about parenting, what it's going to be like, preparing them for that transition. And this really helps to increase trust, help seeking emotional regulation and coping skills. And so just a plug for that program for sure. And then lastly, I just want to go over some treatment goals. When we think about treatment, certainly there's medications and there's prescriptions. But what are the patient's goals and really developing this plan together? What are some of the current interests in treatment? Again, are they ready? Are they not ready? What supports do they have in their community, at their jobs, legally? Understanding the risks and benefits of all approaches, treatment and not treatment. What are the risks of both of those? If you're in a clinic and there's a contract or some program, then going over those rules and safety precautions, and just making sure that there's availability of wraparound care, some sort of 24-hour access, a number that patients can always call if they have a concern. And so I just want to end with a couple of conclusions. So we talked about social drivers. I hope that you recognize that they do influence the health of patients with substance use disorders and those who use substances in pregnancy. Stigma and structural barriers impede patient engagement. Um, and really trying to have a patient-centered approach is really important for our patients navigating substance use and social challenges, thinking about having a trauma-informed sort of session for anyone who's going to interface with this patient population. And then to the extent that you can, incorporating interdisciplinary teams has been shown to improve some maternal and infant outcomes. So I want to transition to a little bit of Q&A, and then I think we'll take questions perhaps at the end. But as a maternal fetal medicine specialist, I take care of the pregnant individual, the complications of their pregnancy, but I don't know everything. And so I am so um, honored and thankful for Cheyenne Somerville and individuals like her who help us care for patients with substance use. And so I just want to introduce Cheyenne. I don't know if you want to say hello. Um,
Hi.
but Cheyenne works in our clinic. And Cheyenne, maybe you can just give a couple words about like when you started and how long you've been with the clinic and kind of how you interface with our patients.
I started in 2020. Um, I meet with the patients. I go over like the readiness rule. We discuss what they see as far as how they want their treatment to go. It's not a one size fit all thing.
Mhm.
What worked for me? Oh, I'm in recovery. Um, let me go back there. I'm a little nervous, but let me go back there.
Okay.
I'm in recovery. Um, and I chose this field so that I could give back. I know when I was coming through, when I was getting myself together, it wasn't peer recovery coaches and things like that. So I had to figure out how to get through. My kids was in foster care. I delivered my son and they took my son from me from the hospital. So it was like a whole process. I understand, I understand the women that come through our clinic. I have been through most of everything that they have been through. And when Dr. Townsend said, people don't just wake up and choose to start using illicit drugs. That is so true. A lot of trauma is in there, and it's a lot of it's a lot of guilt
Mhm.
and fear, and it's a lot that goes with it. So if you so
Yeah, that's it.
I
I
get
mean,
emotional. You get empathetic. You have to be empathetic. Like, it's hard. It's
yeah.
hard. And with everybody doesn't have a support team, so if we could be that for them, that's a plus. I don't know, I think I just went several different ways,
No,
but
I like that. That was perfect. I appreciate you giving that background. I think one of the things I wanted to make sure that the audience understood is just what is a peer recovery coach? What do they do? And like what's your role?
okay, so a peer recovery coach. I'm giving y'all the clinical version because that's what I did. Is a trained individual who use their personal experiences with addiction to support others in their recovery journey. So we provide emotional support, resource connections. We help with personalized recovery plans, goal setting and accountabilities. You know, try to be that support for them.
Right. And again, you spoke a little bit about your journey,
Yeah.
but were there gaps or did you wish you had a peer recovery coach? Is that something you would have accepted?
Thinking about everything now from the place that I'm in now, yes, I would have wanted, you know, I think I wouldn't have made as many mistakes as I did. Um, if I had somebody who knew some information, like I had to figure everything out on my own.
Yeah.
And I ran into some walls and I made some mistakes. Out of the 16 of the 18 months that my children was in foster care, I was blindly finding resources. Like I was stumbling upon stuff after a couple of failed tries. If you have somebody in your corner that has different resources already set up for them, then it wouldn't be so hard.
Yeah. And I think also as someone who cares for this population, I don't know all the resources, right? Like so it's great when I have a social worker or when I have someone who's been through this to say, okay, well, I know about this place, I know about that place, so that we can sort of come together to take care of the patients.
Yes.
All right, next question. What are some of the social drivers that you should see patients deal with who have substance use disorders or who use substances, and how does it impact their care?
Not having support.
Mhm.
So let's say, for an example, a patient, a person we care for has multiple children. Let's say two or three children. Um, but they want to go to treatment. Treatment programs are not taking two and three children.
Mhm.
They have age limits. Some of them want to go in as a couple with their spouse. Um, it's a lot of like things to consider. Um,
And I think I've seen that too, Cheyenne. I think we take care of patients and they want to go into the recovery. They want to be in treatment, but that means they have to leave their child behind. They have to leave
right,
their family behind. And that's a hard ask. And I think, on the one hand, the programs, they have a structure and that's the way that they have it. But it would be great if we could figure out a solution that centers the patient and their families and the program. So
right.
um, you know, I,
Yeah,
I definitely, I definitely see that. What are some resources that are available to patients with substance use disorders or those who use substances to address some of the social drivers of health?
resources. So, they do have women and children programs.
Hmm.
Uh, uh, the FRP program. I
Hmm.
say this because this is one of the programs that I stumbled upon.
Hmm.
So the FRP program, Family Recovery Program, they provide they I loved it because it helped me accountable.
Hmm.
So they do urine tests every week. Uh they help reunification with your children. They set up visitations. Now they have a whole building where they're housing some people now. So um they set up their own little treatment center program. But that was a great program. They helped me so much. Like, what else? Our legal aid program, Better Together,
Hmm.
mental health services, because it has to be a holistic thing. So, with with substance use disorder, you need to attack the mental health issues and all that. So, peer recovery coaches,
Yeah.
uh, doctors that understand, and don't judge.
And I think between you and our social worker, even some of the handouts that we have, I mean,
Yeah,
I'm learning about resources all the time. Many of our patients don't have a working phone, and so
That
that
too.
we can't contact them. And so there's programs out there so that we can get them phones. There's
Hmm.
programs for transportation. There's, food banks, all types of things. And so I think just as each individual clinic and health system, you sort of have to figure out what's in your area, in your region to help the
Yeah.
patients in that area. It's not a one size fits all. It's certainly like getting out in your community, getting out and understanding sort of the landscape of resources where you are for sure.
Yeah. Yes. Most definitely.
I have one more question and then we'll open it up to the audience. And this is a hard one because I don't even know if I have an answer, Cheyenne, so don't feel bad. What needs to be done by clinicians or systems to reduce the burden of social drivers on patients with substance use disorders? What do we need to do if we had all the money in the world?
If you had all the money in the world. um, Invest in my treatment program. I don't know. So yes, like taking accountability. I don't know.
I feel like there's so many things.
Partnership,
Yeah.
partnership, partnerships like understanding,
Hmm.
um, empathy, support. Like
These
that's
don't cost any
basically
money.
that's I don't know. As long as they feel like they have somebody that understands,
Hmm.
build trust. I don't, I don't know exactly how I was stuck on this question because I really have like I could say a lot of things, but I really think trust and support, empathy are at the top of it. Uh
That's really helpful to hear because, again, so many things cost a lot of money and it doesn't cost anything to be compassionate, to
exactly.
be supportive, or to be empathetic. And I think that to me just shows that this is just a mindset. We have to change how we treat people. We have to change how we see people, um, so that we can really care for them the way they need to be cared.
Yes.
Yeah, so I really appreciate those words because throwing money at it may not even be the right thing if we're not going to be empathetic and if we're not going to be sensitive to the things that individuals are going through.
Right.
Yeah. Thank you so much, Cheyenne, for those words and for all the knowledge and wisdom and time you take for all of our patients in this area. Thank you for sharing your story. You are so appreciated. So I just wanted to share
Thank you.
that. Okay, we will now take some questions if anybody has any.
Hi, Dr. Tansel. I love you, Cheyenne, to pieces. I had the privilege of working with Cheyenne for 3 years. She is the reason the care that we give those patients at university was awesome. I think we need to take all the money in the world and clone her. That's what I really think we should do. But my question is, one of my biggest frustrations is we can do all these great things outpatient, but when the patients go in the hospital and we have people judging them saying she's drug seeking, but yet this is her fourth C-section and she's been, in recovery for 10 years and stable on a dose of Suboxone, but when they're facing the discrimination that they face in the hospital, like how do you because I always tell patients, be prepared,
Hmm.
right? Like I think that that's part of the boat that we miss sometimes is those support staffs and the hospitals are just as important as showing this level of compassion. And you are correct. It doesn't cost money. Well, it costs money to train people in trauma-informed care, but it doesn't cost you to be compassionate. And I also will say that I think that everybody needs an OB peer recovery coach if you're doing anything, and Cheyenne should teach them how to do it. My thoughts. But that's my biggest frustration is we do all these
Yeah.
sometimes things outpatient, but then they go to deliver and it's just not
Yeah.
a great situation.
I hear you 100%. And I'll just share a past experience. So, I worked at the University of Michigan for 5 years and we had our clinic, and it was something that we consistently heard from our patients. They loved the clinic, but it was different people in the hospital and, they didn't want to always deliver there. And one of the things that we did was we did not only the trauma-informed training outpatient, but we did trauma-informed informed training inpatient. We had all the nurses, particularly on the antepartum unit and the postpartum unit, go through their training, and it was led by our psychiatrist, myself, and others from the clinic. And it was, I think, when we were able to talk about these things and sort of not make it about the person and about the patient, but about all of these experiences surrounding those individuals, all the circumstances that they're dealing with, and they could see the whole story and not just what was written in the problem list. I really think that helped, and the feedback was phenomenal for sure. So I agree. I think it's not just the outpatient team that has to be trained. It's everybody has to be educated that this is a chronic condition. This is, something that patients are dealing with. No one chooses this. No one wants this. Everybody wants to do right by their baby. Everyone wants their babies to be healthy. So we really have to not only communicate to that to our patients, but to our own colleagues, for sure. Any other questions?
Thank you so much, Dr. Townsell. And just to echo what everyone has been saying as well to Cheyenne, thank you for sharing your story and for all that you do. And if folks do have questions, you can unmute or you can put the question in the chat and we can definitely get to it. We do have a few more minutes. In the meantime, I'll just go over again to obtain your CME or CEU certificate. If you are interested, right after today's session, you'll be able to log into your OASIS portal and you can access the evaluation, and then you'll be able to download your certificate right from there. And then it'll also come in by email from our Max training email as well. I think someone has raised their hand. If you had a
Yeah,
question.
that's me. Hi, Dr. Townsell. My question is about what you spoke about earlier, having like everyone from the security guard staff on through who interacts with patients be, compassionate, like we were just talking about and Cheyenne shared about. Wondering if you have any experience actually like engaging all of those staff at different levels and like what that looked like and how successful that was.
Yeah, so I helped the team create a trauma-informed sort of implementation guide. So there's like handouts, there's like didactics, and there's in-person training. And not every section or sector is, good for in-person training. So what some teams decided to do was do email blasts and sort of send out the information on a weekly or monthly basis. Some teams had in-person training. There were different ways that we implemented it. I can certainly share some of those resources with Tracy and others, and we can make those available, and that they're openly available now. But it really has to be a health system decision, right? Because like there's so many different departments within the hospital that the health system has to decide that this is important, and they have to think about how they want to implement it. Certainly, we can try to, from the ground up, do things, but I think really it's best when it comes from the top down, so that everybody's on the same page. But there are a couple of opportunities and sort of free references that we can share for sure.
Thank you.
Hmm.
Happy to share as well.
Any other questions?
And then again, just a plug for, of course, for Max for Moms. If you do think of any other questions after the fact, you can contact us at Max. You can call our consultation warm line anytime. You can send us an email and we're happy to help. And this I'm recording and the slides is also going to be emailed you and put on our website within 1 week. Thank you, Marciel. Our number, our website is in the chat. And if you have any other questions, you can put it in the chat. You can unmute if you're interested.
I was just going to make one more comment that I didn't make before. Sometimes I get a question about, well, I met a patient and it was really hard to get through And I only have 15 minutes or I only have 10 minutes or 5 minutes with the patient. So how do I break through that? And my response was, that demeanor and that position by the patient didn't happen in 5 and 10 minutes, right? Like that's chronic exposure to individuals who have stigmatized and hurt or traumatized that person. And so we as clinicians have to be resilient and we have to continue. Like we have to press forward every single time. We have to be individuals with kindness because trust is not given, it's earned. And so I really think that it's not for us to say, well, I was nice and I don't know why it didn't work. It's people have to be able to trust us, and trust only comes from sort of continuously being found dependable and supportive over time. And so I would just encourage us all to not think that this is something that can be, a relationship takes time to build. And I just think that we have to take the time to foster those relationships with each patient.
Absolutely. Thank you so much again, Dr. Townsell. Thank you again so much, Cheyenne. We can end it here. I am happy to stay on if there are any other questions. But again, your evaluation will be available in your Oasis portal now. So you can log in to complete that within 7 days, and then you'll be able to access your CME or your CEU certificate. And if you do have any other questions after the fact, you can always contact us at Max.